So the topics to be covered, as Dr. Schweitzer said, are going to be labral pathology and its relationship to femoral acetabular impingement, chronic groin pain, and then tendon disorders. And depending on how much time I'll have, hopefully I'll be able to cover all the tendons. There are quite a few in the hip joint. First, let's look at labral tears. And the symptoms are usually pain, clicking, and locking. Etiology is not always known, but in most cases it's probably either related to trauma, subtle or unsubtle dysplasia of the hip, osteoarthritis, and impingement. On MR, to evaluate labrum, you could do routine axial images, but more valuable are oblique sagittal, oblique coronal, depending on how people call them. People have also written about radial imaging. You could do direct and indirect arthrography, and finally, there have been a few articles using traction on the leg and the foot area to increase the space at the joint and therefore increase visualization. Basically, I think most institutions do the oblique imaging. The normal labrum is triangular and homogeneous. It's thicker posterior superiorly. The torn labrum is usually located superior anteriorly. You may see signal alterations, pretty much like everywhere else in the body. You may see deformity, detachment, or cysts. And you have to keep in mind that the asymptomatic individual, especially the older individual, has variability in the signal and the shape of the labrum. There can even be an absent labrum and cartilage undercutting. So there are a few things to keep in mind. Now, when we look at the labrum, we have to remember that it's a horseshoe-shaped structure. And it is discontinuous inferiorly, where you have the inferior transverse ligament. So when we look at post-MR arthrography of the hip, there are a few things we should be looking at. First, we look at the labrum, and this labrum is very nicely triangular. We look at the recess. This little recess here between the capsule and the labrum is a normal finding. And actually, when you don't see that recess, you should consider pathology or some labral disease in here. Other things to remember is that you can have an undercutting of the cartilage going underneath the labrum, not to confuse that. And then the final thing that we need to remember, and sometimes it's actually very prominent, you can have at the junction of the cartilage and the acetabular fossa, you can have this little defect, which sometimes can simulate disease. Finally, what we need to remember is that the transverse ligament sitting here, we're actually not seeing a tear of the labrum, but we're just seeing the inferior transverse ligament. And I'm going to speak about it in a second a little bit more. So when we look at this transverse ligament, here it is on an axial inferior image. And then if we have an axial image, or if we have a coronal image at this level, or at this level, we're going to see the junction of this fluid in the joint with the inferior with the transverse ligament, and it could look to you as a tear. So basically, you should not confuse the junction of the labrum and the transverse ligament with labral tear. These are more examples of this little inferior transverse ligament, as we see here. So don't call labral tears inferior medially on coronal images. Keep in mind, we talked about this, the junction of the transverse ligament with the labrum, but keep in mind there have been reports in the literature about sublabral sulcus that are found posterior inferiorly. There is controversy, by the way, about the sulcus that is found superior anteriorly, and most people don't believe it exists. But this little sulcus here, posterior inferiorly, is something to remember and not to confuse with a tear. And here we have an example. Here is the inferior labrum, and we see that little posterior sulcus. Okay, other things to keep in mind when you're looking, if your axial images are not of very high resolution, you could see this little dot, this little line here, and that is a pitfall. That's actually the iliopsoas tendon adjacent to the anterior labrum, and you shouldn't confuse that with a tear. So when we look at labral pathology, we can divide it either to tears along the morphology, the outer, the peripheral morphology of the labrum, or as detachment of the labrum. And then you can have hypertrophy of the labrum with cystic degeneration associated with these same changes. Usually when we see hypertrophy of the labrum, it is related to dysplasia, because one of the ways for the body to react to provide more stability to an unstable femoral head is to hypertrophy the labrum. So here we have examples. This is an irregular anterior superior labrum with probable detachment, as we could see here on fluid-sensitive images. Here we see that we have cystic degeneration in the labrum as well. And here we have more examples, very similar. We see that that space that we saw, and I talked about the cartilage undercutting, this is too much for cartilage undercutting, and we have actually a labral detachment and a tear. Now, one of the findings that you should be looking for is paralabral cysts, similar to the shoulder. When we see these paralabral cysts, and don't confuse these paralabral cysts with the recess that I mentioned to you about. Labral cysts are associated with labral tear. The way to distinguish them from just the labral recess is if you don't see communication with the joint. So you have to follow it on sequential coronal images, and here we see it, and we never really see communication of this fluid collection with the joint. So this is an indication of pathology, a labral tear, and even if you don't see the labral tear, think about its existence. Now let's talk about this hot topic that Dr. Schweitzer alluded to, and it is a fun topic to talk about. It's relatively new, and this is the femoral acetabular impingement. And it is believed now in the literature that this is probably the cause for early osteoarthritis. So when we see osteoarthritis in young people, that's what the real, the cause of it is. Some people lump hip dysplasia with femoral acetabular impingement. Some people consider them two different entities. But basically with femoral acetabular impingement, we sometimes have subtle hip dysplasia, or people call it acetabular rim syndrome. And unlike a femoral acetabular impingement, which usually affects either the labrum or the cartilage, when we have hip dysplasia, we usually see superolateral acetabular fractures and labral injury. So when we talk about femoral acetabular impingement, we are specifically talking about young people. They tend to be athletes. They don't have to be, however. They have pain in adduction and internal rotation and hip flexion, as we could see here. Now, in the literature, and what people have used to say is that the x-rays are normal, but I put this question mark because in actuality there are subtle abnormalities that now we look more carefully in. And in my opinion, one of the more fun things about femoral acetabular impingement is that it allows us now to look at plain x-rays with a different eye. So basically what we look on the x-rays is acetabular femoral mismatch. People, you must have heard about the CAM effect and the pincer effect, and I know that when I first read about it, I was very confused. But basically, the CAM effect, all it does is imply that you have an abnormal femoral head. So we'll see that with anteversion, we'll see it with abnormal head-neck offset. And then when we talk about the pincer mechanism, we're actually talking about a normal femoral head, but an abnormal acetabulum. And this manifests as either retroversion and profundo, and in reality, the CAM effect and the pincer mechanism are usually coexistent in patients with femoral acetabular impingement. So I don't think it's so important to recognize the different mechanisms, but just to know what they're about. So basically, what do we look for with acetabular impingement? We look for cartilage abnormalities, labral defects, osteoarthritis. The point about making this diagnosis is that in young people, surgery is indicated, and what they do is they go in and reform, or they shave these little bumps at the femoral head-neck offset. When I first heard about this surgery, I couldn't believe it, and I thought it was outrageous. But then when I thought about it, we do the same thing for anterior impingement in the ankle. We shave the talar or anterior tibial osteophytes. We shave osteophytes of the acromion. So it is not such an outrageous surgery, especially when they do it arthroscopically, and then there is less damage to the structures involved. So basically, when we look at a normal hip, we see that the anterior aspect, the anterior wall, is more medially positioned relative to the posterior inferior wall. And when we look at the pincer mechanism, you see that the anterior wall extends more further in. So you have actually a deep acetabulum here, or acetabular profundo. With the cam effect, the abnormality is at the junction of the femoral head-neck junction. So you have this little bump here. And this is a combination of both effects, the cam and the pincer effect. So what do we look for on plain films? We look for dysplasia, decreased coverage of the femoral head, and shallow acetabulum, and I'll go through that a little bit more slowly in a second. With the femoral head, we look for abnormal head and neck offset, the femoral pit, that famous femoral pit that we used to read about, and people always said, oh, that's a normal finding. Don't confuse it with a tear. Well, now we know that it's probably related to impingement. And then we look for the femoral bump, and in the acetabulum we look for the os acetabulum. Again, we used to look at it on plain films, didn't make anything about it, but now we know that it's probably related to femoral acetabular impingement. You look for lateral cysts, sclerosis, retroversion, and finally osteoarthritis. And basically in the femoral, on MRI, you see the same manifestations. In the femur, you see edema, you see the bump, you see neck cyst or pit, and in the acetabulum, you see these findings that correlate with the plain x-rays. So now let's look at these a little bit more carefully. This is a normal femoral head-neck offset. Look at it here, where there is this extension laterally and less of that nice contour or deepening between the junction. This patient also has a dysplasia. There isn't enough coverage of that head. This is a 22-year-old with hip pain. And look at the radiographic findings of impingement. On the AP view, we actually don't see much. We just see these little sclerotic changes here, maybe a radiolucency here. But when we look at it on the oblique view, on the fragile view, notice this little bump, this abnormal head-neck offset. We don't have that nice contour here. Notice also that you have radiolucencies and sclerosis involving the acetabulum. And then this is a different patient, a 34-year-old female with bilateral hip pain. Again, we see these kind of little sclerotic changes. On axial images, we see that famous femoral pit that, as I said, we used to ignore before, and now we know it's probably related to impingement. And in this patient, we even had this subtle abnormality bilaterally on bone scanning. This is a 51-year-old female with chronic groin pain, femoral bump, and labral tear. And notice here, we see that little bump here. We actually even see edema associated with impingement here, and we see a labral tear. The anterior labrum is completely abnormal, and again, we see that labral tear. And finally, this is the last case that I want to show you, and we see here that there is also a large cartilaginous defect. There is edema in the femoral head, and there is edema in the acetabulum, indicating to you that what we have here is impingement. And lastly, we see here an os acetabulum, increased signal in the acetabulum, and abnormal anterior labrum. So basically, these are the findings that we look for. Another thing that we look for is retroversion. When we look at an AP view of the pelvis, the posterior wall of the acetabulum should not intersect with the anterior wall. This is normal. Compare it to a retroverted acetabulum, and if you follow the anterior wall, it actually extends more anterior, or more lateral, we should say, relative to the posterior wall. So this overlap here, or figure of 8 type of appearance, is consistent with a retroverted acetabulum. Now, I want to warn you about that. I've actually, since I've learned about the retroverted acetabulum, I've been calling it with practically almost everyone. So you have to be very careful. It has to be a perfect AP. The patient shouldn't have increased lordosis. Sometimes scoliosis or just a little bit of rotation can make it look like that. So here is a 22-year-old with left hip pain, and we see the retroverted acetabulum. And follow, this is the posterior, this is the anterior wall here, and you could see that it extends further out than the posterior wall. And this only has to happen in the superior aspect. It doesn't happen to have, it doesn't, when you have a deep acetabulum or acetabulum profundo, it's only superiorly that we're talking about this phenomena. I'm going to stop here and talk now about chronic athletic groin pain. This is actually also an important concept that we need to recognize because it's not just one disease, it's probably a combination of multiple abnormalities. And the reason for that is because the groin area is the junction of three major body parts. So you have the abdominal muscles coming here, you have the pelvic structure in here, and then you have all the muscles of the lower limb, and they're all pulling on this poor little area here. So when we have chronic athletic groin pain, this is very common in athletic endeavors such as kicking, sprinting, changing direction, very common in football, hockey, soccer players. And basically what we look for is pubic pathology. It may be related to adductor tendinopathy at the insertion here. It may be related to the bones themselves, osteitis pubis, instability with step-off, stress fracture. Again, things that we could see on plain films. We used to see them, not make a big deal about them, but now we know that this is quite an important finding, especially in young people. And then you can have sports hernia, which is related to weakness in the area of the inguinal ligament. And finally, the same thing, rectus abdominis tendinopathy in here with defects at the rectus. So let's look at a few of those examples. Here we have increased signal in the region of the symphysis pubis, and we need to differentiate osteitis versus stress fracture versus adductor strain. And it's not always going to be easy. Sometimes it's easier when we know the age of the patient. In elderly individuals, we have to think harder about insufficiency fractures. They could be bilateral. In young people, it tends to be more osteitis. This is an example of an adductor strain in a professional baseball player, and we see here extensive edema in the adductor brevis and in the adductor longus attachments. We can look at it on axial images, and we actually see partial detachment of the adductor longus. And this is the sagittal image on the same patient, and we see the detachment of the symphysis pubis. Now let's look at other commonly injured tendons, and there are many tendons that insert in that area. I'm going to try and cover them all. We can think about the hamstrings inserting in this area. You have the iliopsoas inserting to the lesser trochanter, the glutei, gluteus medius and minimus inserting into the greater trochanter, the rectus femoris, and the sartorius. So actually this kind of covers it, and basically I'm going to start with common hamstring tendon injury. The hamstrings insert into the ischial tuberosity. Injury to them is related to sudden violent force or repetitive trauma. We usually see it in the young athletes, and it is a tear of the conjoint tendon, right? You have the biceps femoris, the semitendinosus, and the semimembranosus inserting. In adolescents, however, we usually see an apophyseal disruption in that area. Patients describe pain, weakness, a palpable defect may be noted clinically, or if they have significant retraction, there may be a distal mass. Treatment is initially conservative, but if it's significant retraction, they will go in and treat it. And MR, it's very easy to see the hamstrings. We can see them on coronal images, axial images, and basically what we look for is the same as we look with any tendon injury: hemorrhage, edema, tendon disruption, retraction, or muscle atrophy. I just want to remind you, because I think it is important to always remember how plain films look. that sometimes you can see this large cystic radiolucency. You can confuse it, especially if you see it in a young kid, as a chondroblastoma, an aggressive cartilage lesion. These are secondary findings to a repetitive hamstring injury. So keep that in mind when you see these radiolucencies in the ischial tuberosity. And just to show you again, the mechanism of injury is hip flexion with knee extension. So basically what we're doing is lengthening the hamstrings and causing it to tear. And here you see an example of an avulsion fracture in this patient, or in this drawing, I should say. Okay, so this is a runner who had a partially torn right hamstring tendon, and we see here extensive thickening of the hamstring tendon, of the conjoined tendon. We see irregularity of the bone. We actually see a defect here, and on fluid-sensitive images, we could see fluid going into that defect. So this patient on plain films did have irregularity, as we see here. When we look at axial images in the same patient, this is the semi-membranosus here more anteriorly, and we see this tremendous increased signal and heterogeneity in the common tendon of the semitendinosus and the biceps femoris. Interestingly, it's usually the biceps femoris more commonly that it's torn, and one of the theories for that, and I think it's an interesting theory, is that the biceps is innervated by both the tibial and the peroneal nerve divisions of the sciatic. So because it is innervated by two different nerves, there is this dyschrony of action of the muscle, and therefore it's more associated with tears. So this is a complete left hamstring tear, and here we see retraction. This was also a professional athlete, and in this kind of situation, you have to go in and repair it, and we see here the absence of the tendon. Let's look at the rectus femoris. The rectus femoris is particularly susceptible to tears or strains because it has all the qualifications for tendons or muscles that tend to tear. It's fusiform, it's a long muscle, it crosses two joints, and it has an increased predominance of fast twitch fibers. So it tears with hip extension, as we see, and knee flexion, as we see here. The tears can occur either at, we could look at it here, either at the origin of the tendon, at the anterior inferior iliac spine. It can tear here at the proximal tendinous junction, or it can tear at the deep musculotendinous junction. And this we just covered, so basically it can either tear here, or at the deep musculotendinous junction, which is more commonly in the thigh. It is related to a violent eccentric contraction. Eccentric contraction means lengthening of a muscle at the same time as it contracts. So that puts contradictory effort on that muscle. So it's common in sprinters, kicking, soccer player, football, basketball. You can develop tears, then you can develop fibrosis and scarring, and finally you can develop a pseudocyst. And the treatment initially is conservative, but surgery may be indicated. One, they can develop compartment syndrome. They can develop chronic strains, which can be very painful with scarring. They can have complete tears with retraction. You may need to do a hematoma evacuation because it's very common for them to have a hematoma. And finally, some surgeons will even go in and remove the scar because that scar is very longitudinal. It's a long scar, and it actually causes shortening of that muscle, and it causes it to be very predisposed to recurrent tears. And actually, the most common predisposing factor to rectus femoris tear is a previous tear. It kind of sounds funny, but it's the truth. Okay, so what is interesting about the normal anatomy, and going back to that deep musculotendinous junction, is that you have this direct and indirect heads of the rectus femoris, and the direct head remains anteriorly as you descend down the thigh, while the indirect head kind of dips in and becomes within the intrasubstance of the muscle, and that's where it commonly tears. So let's look just a little bit more about the normal anatomy. Here we see the anterior head, and this is the indirect acetabular head. And here we see them coming closer to each other, and finally they're joining with each other. And then when we move more anteriorly, we could actually see that the deep or indirect head is now starting to dip into the rectus femoris muscle, and we see it here and here. On coronal images, this is the origin from the anterior inferior iliac spine, origin from anterior inferior iliac spine, and origin from the acetabular ridge. This is actually, we're not seeing the origin, but here it is. And keep that in mind, that's another pitfall for labral pathology, because sometimes you'll see that extra little line here, fat in between them, and you can confuse it with a tear. So basically, remember always plain films. Here we have this bony prominence here consistent with healed rectus femoris avulsion from anterior inferior iliac spine. And this is an example of an avulsion of the rectus from the anterior inferior iliac spine. But this is what we more commonly see, and this is something we should be recognizing. What happens is you get tearing along that deep indirect head, you get fluid around it, and you kind of get this bullseye appearance. Here is the tendon, and here is all the edema and hemorrhage around it, and we see it here. Here is the tendon and bright signal. Usually these are type 2 tears, musculotendinous tears. Same thing here. This is post-contrast, and we see here increased enhancement around the tendon and the beginning of formation of scar tissue. Now notice here on this axial image it looks like we have two tendons, but in reality this is the tendon here and this is a longitudinal scar, and these longitudinal scars are what predispose it to a tear. Just going to finish with the iliopsoas avulsion. Iliopsoas avulsion, we talk about it in elderly people. When we see iliopsoas avulsion or avulsion at the lesser trochanter, we have to think about a pathologic process, an underlying tumor. It's not true for young people. And basically, normally, we have actually the many multiple insertions of the iliopsoas tendon into the lesser tuberosity, inserts just below it, inserts also directly into it. And here we look at it on this normal and look at this patient on the other side has an avulsion at the iliopsoas. Another patient here where we see large amount of edema at the iliopsoas insertion. We see thickening of the tendon because that tendon has so many multiple attachment sites, it often does not retract. So you have to have a very violent injury to cause this tearing. Now the case that I'm showing you right now is actually in an elderly individual, and there have been at least one report that I know of two elderly women who barely had any trauma and had these tendinous tears without underlying pathology. So keep that in mind. And we've actually been seeing quite a few of them also in elderly individuals. I think my time is up, and as I expected, I knew I wouldn't go into the gluteus medius and minimus, but there are a lot of articles on that in the literature. And thank you very much.